numbers in 100 patients and 20 minutes.
Yeah, good morning and thank you for the invitation to talk about the new guidelines, valvular guidelines. So the guidelines discuss each valvular disease in the following format. First, they discuss the diagnosis and follow-up, then the medical therapy, and then the intervention. Because of our limited time, I won't be able to discuss and to review systematically all the valvular disease, but I will point out what I have found to be important new recommendation or new definitions. Another new principle in the current guidelines that each valvular disease is now presented in 4 stages, the same stages that we see with the heart failure. So we have patient at stage A, where we have patient at risk for development of valvular disease. In stage B, we have patient with progressive disease, which is not significant disease. In stage C, we have patient with severe disease but are asymptomatic. In C1, we find the patient where the left or right ventricle is compensated, whereas in C2, we have the patient with decompensation of the ventricles. And in stage C, we have the symptomatic patient with severe disease. Some words about SBE prophylaxis. Today, the only procedure where SBE prophylaxis is indicated are dental procedure, and it is recommended only for patients with high risk. For example, patient with prosthetic valve, patient with infections, endocarditis, previous infection, endocarditis. We don't find in this list, for example, patient with rheumatic disease and patient with severe organic disease, for example. So those are the new, consistent with the SBE guidelines, actually. Heart and valve team. Heart and valve team is an important concept that is being discussed in detail in the current guidelines. With the development of the new transcatheter procedure, the heart and valve team is crucial for any valve center, and it should compose cardiologists, interventional cardiologists, as well as imaging specialists, of course the surgeon, anesthesiologist, and nurses. And the aim of the team is to optimize the patient selection for the available procedure, and they do emphasize that patients with complex heart disease is the treatment for patients with complex heart disease is best achieved in centers that can provide all available options for both diagnosis and management. That means a center of excellence. And what is the definition of center of excellence? It should have expertise from multiple disciplines. It should be able, again, to offer all the available both diagnosis and management options. It should participate in registries and adhere to guidelines, and of course participate in quality improvement processes and report their mortality and success rate. So the first disease I will mention is aortic stenosis. So this is an example how the guidelines present the stages of disease. So for example, patient with bicuspid aortic valve are patient with risk for the development of severe aortic stenosis. And then in C, we have again the patient with compensated left ventricle versus patient with decompensation of the ventricle. In group D, in the symptomatic group patients, we have actually now 3 groups of patients. We have the high gradient severe aortic stenosis. We have the patient with low flow, low gradient aortic stenosis with reduced ejection fraction. This is the group of patients where infusion of low dose dobutamine during stress echo will show persistent reduced aortic valve area but increased velocity across the valve. And the third group, this is a new recommendation. We have the severe low gradient aortic stenosis, or the paradoxical low flow severe aortic stenosis. This is a new group of patients that was introduced in the past years by the Pibereau and Dumensil. And what is correct, they are patients with preserved ejection fraction but reduced stroke volume index, which was defined less than 35 cc per meter square. Those patients has reduced aortic valve area, but the pressure across the valve is reduced, secondary to the low flow, and those patients have normal blood, assuming the study was done with normal blood pressure. And that's their report when they have shown that this group of patients AVR improved survival for those patients. The orange line represents the patient survival following AVR, whereas the dashed line are the patients who were treated conservatively. And actually, from our data, we showed the same phenomena. So for those patients who are symptomatic, and we are sure clinically, hemodynamically, and anatomically that this is the reason for the symptoms, then it is reasonable to send those patients for AVR. And it is important for the echocardiographer to go through all the pitfalls in the echo, for example, measuring LVOT, that can be a source of error. And also important point for those patients, the aortic valve index area have to be lower than 0.6. That's the definition. In the current guidelines, we find more recommendation for stress exercise, and this is a new indication where they find it's reasonable to stress patients with severe aortic stenosis to confirm absence of symptoms. And this is the summary of the indication for intervention. So patients with severe high-gradient aortic stenosis, consistent with the previous guidelines, if they are symptomatic as well as asymptomatic, but decompensation of left ventricle, or have another indication for surgery, AVR is indicated. For those patients who have very severe aortic stenosis or abnormal exercise tests, it is reasonable to refer those patients for AVR. And the patient with rapidly progressive disease are considered 2B indication. For example, in the European, it's 2A indication. So. And for those patients with low gradient severe aortic stenosis, we have here the new group of patients with the paradoxical low flow, low gradient severe aortic stenosis. Catheter aortic valve replacement, it's a new procedure, so we have new indication. It is clear that patient who has low or intermediate surgical risk should be referred for surgical AVR. It's clear that the decision for TAVR versus surgical AVR should be done as a part of the heart and valve team. Patients who have prohibitive surgical risk and predicted survival of more than 12 months should be referred for TAVR. And for high surgical risk patients, a TAVR is reasonable. Aortic regurgitation. So most of the patients with aortic regurgitation has chronic disease and slowly progressive disease. This is the summary of the indication for intervention. Consistent again with the previous guidelines, and it's obvious that symptomatic patient as well as asymptomatic patient with decompensated left ventricle or other indication for cardiac surgery should undergo AVR. For those patients who have remodeling of the left ventricle and enlargement of the end-systolic diameter more than 5 centimeters, it is reasonable to send those patients for AVR, while enlargement of the end-diastolic diameter of more than 65 millimeters is considered to be indication. We don't find here any stress indication. CMR, in the current guidelines, we find a new indication to evaluate valvular disease with CMR, and this is the first one I will mention. For those patients who have suboptimal echo images, the author finds CMR accepted first to evaluate the severity of the disease as well as to assess the LV function and dimension. Another change in the guidelines for the bicuspid aortic valve, aorta replacement for patients with enlargement of the aorta is indicated when the aorta is larger than 5.5 centimeters. They do mention that for high-risk patient, i.e. patient with rapid progressive disease or patient with a family history of aortic dissection, then aorta replacement should be when the aorta diameter is larger than 5. In mitral stenosis, we find a new definition for mitral stenosis severity. So progressive disease will be considered when the area is more than 1.5 centimeters square, and severe mitral stenosis will be considered when the area is less than 1.5, and then we have the very severe mitral stenosis when the area is lower than 1 centimeter square. Pressure gradient is not in the definition for a valvular severity, stenotic severity, but we do find the pressure half time, which we all aware of the limitation of this method. And it seems that the aim of this new definition is to encourage balloon valvuloplasty early in the disease. So these are the recommendations for intervention for those patients. If the patient has very severe mitral stenosis, even if he's asymptomatic, but his morphology is suitable for balloon valvuloplasty, then it is reasonable to send those patients for intervention. And they do mention that, in their opinion, most of the patients should be symptomatic on this stage. Symptomatic patients with severe or very severe mitral stenosis who have, again, favorable anatomy should be referred for balloon valvuloplasty. Otherwise, they should undergo mitral valve replacement. Asymptomatic patients with new onset atrial fibrillation, again, if the anatomy is suitable for balloon valvuloplasty, it is considered to be indication. Patients with progressive mitral stenosis, symptomatic, and have shown increase in wedge pressure during the exercise, then it is to be indication for a balloon valvuloplasty. We don't see here any indication for stress, and we don't see here a pulmonary hypertension indication, which used to be in the previous one. But if we go to the text, it is written that although exercise-induced pulmonary hypertension doesn't have a formal place in these guidelines, a rise in RV systolic pressure between 60 to 70 millimeters of mercury should prompt the clinician to carefully consider the patient's symptoms. So for me, my impression is that there might be a disagreement in the committee, and that's how they solved it. Primary mitral regurgitation. In primary mitral regurgitation, we find a new indication for CMR. We can appreciate the severity of the disease as well as assess the LV and RV with MRI, again, only if the transthoracic images are not satisfactory. And we also find indication for exercise stress. For those patients that we want to confirm the absence of symptoms, we can evaluate them with stress. And the summary of the indication for surgery for those patients with primary mitral regurgitation who are symptomatic and have ejection fraction more than 30% should be referred to mitral valve surgery. For the mitral valve, of course, we prefer mitral valve repair over replacement. We don't have enough data for the patient with reduced ejection fraction, and that is the background for the 2B indication. For asymptomatic patients, but a reduced ejection fraction or a remodeling of the left ventricle, which is defined end-systolic diameter more than 4 centimeters, mitral valve surgery should be done. And we have the following recommendation. Patients who have normal LV dimension and function, or patients with new onset atrial fibrillation, or presence of pulmonary hypertension, if the likelihood of repairing the valve is more than 95% and there is low mortality expected, then it is reasonable to refer those patients for mitral valve repair. Otherwise, we just follow those patients. And for the other group of mitral regurgitation, the secondary mitral regurgitation, this is for Ronen. Basically, we don't have enough data, and that's the background of the limitation. We have a very limited recommendation. Severe tricuspid regurgitation. Patients who have severe tricuspid regurgitation are patients with the worst prognosis because of, regardless of their LV function, RV function, or age. Here we find another indication for CMR, and we find also the 3D echo, again to evaluate right ventricle in the presence when there are suboptimal 2D images. In general, the author of the guidelines do encourage us to repair tricuspid valve functional TR during the time of left side surgery. We all know that up to 25% of the patients following left side surgery will develop tricuspid regurgitation, severe TR, and we know that the redo TVR is carry a high morbidity and mortality. So if the patient has tricuspid annular dilatation or have prior evidence of right heart failure, it is reasonable to repair the valve, and it is demonstrated in the flow chart for intervention for those patients. So patients with progressive functional TR during the left side surgery and have tricuspid annular dilatation, it is reasonable to repair the valve. For those patients who have severe TR, asymptomatic as well as the symptomatic, during the time of, and functional TR, during the time of left side surgery, the tricuspid valve should be treated. In general, tricuspid valve repair is preferred over TVR, and basically both types of prosthetic valve are accepted. It should be individualized to the patient. For patients with primary tricuspid regurgitation and who is symptomatic, it is reasonable to refer those patients for TVR. And I would mention that they do discuss it, that we don't have data regarding the optimal time to refer patients with primary tricuspid severe TR to surgery. And any time that there is discussion about referring those patients to surgery, you always need to discuss the RV function as well as the possibility of irreversible pulmonary hypertension, because failure of the right ventricle is a major risk for those patients. For a prosthetic valve choice for the mitral and the aortic valve, so for young patients younger than 60 years, mechanical valve, a mechanical prosthetic is reasonable, as well for the older one above 70 years, a bioprosthetic, and for both types of valve are reasonable for patients between in the age of 60 to 70. In the antithrombotic therapy, I want to emphasize only one indication, which is that today low molecular weight heparin is accepted as a bridging therapy for patients with mechanical valve. And I had to show an indication for MES procedure. So today, a MES procedure is considered as reasonable for patients during mitral valve surgery if they have chronic persistent atrial fibrillation. So in summary, we have new format to valve disease stages. The heart team, the function of heart team is emphasized and defined. We have new catheter-based procedure and indication. The entity of paradoxical low flow, low gradient, severe aortic stenosis is accepted. We have new definition for mitral valve stenosis, severe mitral valve stenosis. We are encouraged to repair the tricuspid valve during the surgery of left side heart, and low molecular weight heparin as a bridging therapy is accepted.